It's inspiring to think big, especially when you're in medicine. Ask a pre-med why they chose medicine, and they might tell you to cure cancer, or to serve the poor, or to restore people's eyesight. But once the learning starts, they realize a fundamental truth. Realizing big dreams takes a lot of very small work. Stitches you can only see through a magnifying lens. Making house calls in homes with no heat. Pipetting thousands of samples of cells into a big array in a lab at 3 a.m. My big idea as a first-year medical student was that there was a principle in the Torah that should be the foundation of all medical care. It was Genesis 1:26 and 27, where we learn that God created human beings in the divine image. Believing that is one thing, behaving that way is another. It reminds me of a hospital where I once worked that has a huge sign over the main entrance with "Welcome" written in about 20 different languages. Maybe 100 feet from that sign, a patient of mine was turned away from an ultrasound appointment because there was no interpreter available to help her understand the instructions. Great idea, terrible execution. It took years of practice before I began to understand how to do the small work that supported my big idea. It also required regular application of another core religious principle, the one Rabbi Rachel Mikva describes as self-critical religion. The ability to critically examine both our beliefs and behavior is one of the foundations of Judaism. That activity is known as teshuvah, often translated as repentance, but really meaning return, as in a return to the way we were meant to be behaving all along. That self-criticism eventually led to my first book, Healing People, Not Patients, and of course to this podcast at the very same name. Just as importantly, it led me to create a course at the University of Pittsburgh, my alma mater for both undergraduate and medical school, called Healing in Humanity. It's listed as a religious studies class, and it walks the students through the same process I went through in my writing and in my career. Namely, how do we operationalize our most noble big ideas into concrete behaviors that will make a difference for our patients and throughout the system? What we end up learning is that operationalizing noble beliefs often involves what Lord Rabbi Jonathan Sacks called daily, undramatic, yet essential service. Rabbi Sacks shared a 16th century midrash from the Ein Yaakov, in which the sages are debating which principle is the most all-encompassing description of Judaism. One says, Shema Yisrael, the declaration that God is both our God and the only God. One says, love your neighbor as yourself. But the sage who carries the day is named Ben Pazi. He says that the most important principle is, quote, prepare one lamb in the morning and the other towards evening, end quote. Daily routine sacrifice done at the proper time, in the proper way, in the proper place, and my colleagues in quality improvement might say, for the proper person, is the core of achieving any higher aim. With that in mind, I'm proud to share a special episode of Healing People, Not Patients today. At the end of the fall semester, my students at Pitt completed special projects. Each student interviewed a person who experienced medical care that fell short of expectations for some reason. They applied the concepts and skills we learned in the course to propose changes or interventions that could make the system or institution better in a way that would help that person, or someone like them, the next time this situation came up, but with a focus on how they were treated as people. In our final session, the students presented their projects to one another and voted the projects they thought were the best. Today's guests are the three pairs who received the most votes in that poll. I think you'll see why their classmates thought so highly of. Stay tuned after the intro to hear more.
No room for the soul that's in my head. No room for the soul that's in my heart.
When someone's sick, they're not just dealing with annoying symptoms. They're confronting some of life's biggest questions. I'm Dr. Jonathan Weinkle, and you're listening to Healing People, Not Patients. Join us as we explore how to make our practice about complete healing, healing of the body and the spirit. Welcome back. My first guests today are Sophia Smallwood and Tai-Hee Lam. One of the strengths of 21st century medicine is its ability to standardize care using objective indicators like laboratory results or imaging studies in an effort to correct the disparities that result from subjective and often biased evaluations. But as their story tells us, sometimes those objective measures end up overlooking people who don't, quote, fit the script. They developed a project that is data-driven by a personal, individual kind of data that we need to relearn how to listen for. Hi. So as promised, I'm here first with Sophia Smallwood and Tai-Hee Lam, who have a very interesting project to present to us, but I'd like them to introduce themselves first. So Tai-Hee, could you tell us a little about yourself, please?
Yep, of course. My name is Tai-Hee Lam. I am a sophomore at the University of Pittsburgh, currently majoring in natural sciences on a pre-PA track. I am currently in VSA, which is the Vietnamese Student Association Committee, and also the pre-PA club.
Great. Okay. And as some of my listeners may know, I have a fondness for PAs. I worked at Chatham University in their PA program as the medical director for 10 years. So I wish you luck. And both Pitt and Chatham have excellent PA programs. So hopefully we'll be able to keep you in town one way or the other. Sophia, what about you? Tell us about yourself.
Hi, everyone. I'm Sophia Smallwood. I'm also a sophomore at the University of Pittsburgh. I'm a neuroscience major, minoring in chem and religious studies, and I'm the vice president of our Polish club here at Pitt.
Fantastic. And Sophia was modest enough not to mention the other connection outside of these classes that we have, which is that she is currently serving on the student advisory committee for the Conference on Medicine and Religion, which I chair. So that's an exciting sort of outside of Pitt responsibility. All right. So I want to start with just sort of the simple question. Your project centered around a very common disease that nonetheless gets overlooked a lot because it's actually a lot more common even than we believe, which is iron deficiency anemia. So tell me what the project is that you came up with about better treatment for iron deficiency anemia.
So basically, we had Sophia's mother who went through trying to find out whether or not she had iron deficiency anemia through her doctors, and she had went through multiple physicians, and she explained her symptoms, and overall she did not get a satisfactory response or type of care she wanted. I'll probably let Sophia talk a little bit more since that was her mom, but we did come up with a solution. It's more of a AI solution considering our future right now in the world. And it's a deep learning model that we had gotten inspiration from another deep learning model called MyABA, which focused, I believe, on PCOS patients. And it allows you to see all their background and let them communicate with other people. It's like a group chat where they can explain their symptoms and see what other symptoms other patients have to see where they may lie in the condition and where they are in the progress of diagnosing it and how they can help themselves and connect with other people during it.
So Sophia, you, as mentioned, this is a story that's very personal for you. And Tai-Hee talked about your mom having trouble getting the kind of answers that she was looking for. What happened to her that made her feel like she was kind of getting shut out of the care she needed?
All right. So when my mom, right after she had my sister, a couple years after that, she had gone through a couple hematologists after being referred by her PCP or her OB-GYN. The OB-GYN and the PCP were hesitant to help her with the issue, so they wanted her to see a hematologist first. And so she went through the first hematologist, and I don't think they really clicked, but the one that was more impactful to her was her second hematologist. That was like a less than great experience. And I actually got to meet this hematologist over break while I was shadowing. And so it was a weird situation for me because I knew I was like, oh dear. But yeah, so this particular hematologist is very by the books, totally goes off of numbers and doesn't really take any lived experience into diagnostic criteria. So whole ferritin was like 33 and the threshold for treatment iron infusion was 30. And so she was right there at that border mark and she was very symptomatic. And he basically told her to take some iron pills, even though she can't tolerate the iron pills. She had known that for a while. And so she ended up not seeing that hematologist anymore and switched to one that is great. And she's actually both of our hematologists now. She's wonderful. And this hematologist in particular was really good about just having that pull up a chair mentality and really listening to her and getting off the computer, being fully present while she was there in the room with her, and really listening to her symptoms and her lived experience. And they decided that she would get a series of iron infusions. And we're still seeing her today, but she was outstanding. She did a really great job, was really thorough, and she really listened to the patient.
Sure. There's so much to unpack in that little story, which is great. This is what I love. And I want the listeners to notice that I think it took Sophia like maybe 2.5 minutes to tell that whole story, if that. I'm watching the clock and we've been on less than 6 minutes. And kind of highlights one of the themes of our class, right? Which is that you don't need that long of a time to let somebody talk uninterrupted, and all sorts of important data comes out of there if you're paying attention to it. I love the mention of the pull up the chair mentality. We'll talk about that in a second, getting off the computer and really paying attention. I'm going to come back to those in a second, but tell me a little bit about, you said she was very symptomatic and the one doctor wasn't taking into account her lived experience. So what experience was she living? Obviously, one of them was iron pills suck. I don't like taking them. But what else was going on?
So her main symptoms, she was super fatigued and she was having like, I guess like hot flashes sometimes. And she had other symptoms too. But the main one was that she was so exhausted, short of breath. It was like your really classic iron deficiency symptoms when it gets pretty bad. And the doctor basically chalked it up to your mom. So he definitely took that into account, maybe a little too much. But it was almost like he used that to dismiss the situation.
Sure.
As far as like other lived experiences that the other hematologist took into consideration, the first thing she did was rule out a bunch of other like blood disorders that we may have a family history of. So that's one thing that was important, really assessing like the potential for some genetic predisposition for something. And our model will also get into like the genetics behind it, because there's a genetic component that we wanted to put into our model as well. And then I think that was like one of the main things. And I think just the quality of life was not great. And I know in our paper, I found a study that talked about, it was from actually a retired hematologist that worked at Pitt her whole life. And she was touching about how the quality of life for these women with this illness is really poor, and they can actually feel a lot better than they do. And I guess the overarching point is just that, I guess as a woman, she was made to feel like that was the norm for her because that was all she knew. She found out that it wasn't the norm. The first physician didn't really do anything about it.
And there's lots of life circumstances where we make that mistake. You know, aging is another one. Oh, well, you're getting older. What do you expect? And we're starting to realize that normal aging shouldn't necessarily involve like rapid deterioration of memory, total loss of mobility. Like there's a lot of things that we can do to make that better. Being the parent of young children shouldn't be any different, right? We ought to be thinking about that. Taihi, I want to come back to you. Sophia made that point about pulling up a chair, getting off the computer, and yet your intervention is very tech-based. So explain to me how using something that is so high-tech helps to be actually more with what we call high touch. Like how does that actually fuel sort of the individualized, personalized medicine?
So our model, it advocates for patients. So as Sophia was saying, how her mother kept feeling dismissed, and it was the physician just talking and talking and never really pulled up that chair and listened. Even though it's high tech, obviously when our patient is in the room talking about her symptoms to the physician can put these symptoms into the database, but the patient can also as well. And so for it to be high touch and in touch with everyone, I believe that since our model allows the patients to see other patients who have the same symptoms, who are going through the same things, it allows for that human connection to know the patient is not alone and that the patient can advocate for their health. They'll be able to get the care that they need. And so even though it is a little more high tech, more AI to accommodate what like basically the world moving away from papers and writing to more computer and databases things, it still allows for that feeling of humility and humanity. inside our database to be able to keep in touch with your symptoms, keep in touch with everyone else and everything like that.
So you're actually promoting it as a way of connecting with other people who have the same, to Sophia's phrase, lived experience, who you'd never connect with otherwise. And I'm guessing that you're working in some security features to make it better than just hopping into an affinity group on Facebook or Instagram or something like that,
Yeah.
which is decidedly not secure.
Yeah.
Okay.
So even though I'm pretty sure that in our model, you can see how other patients feel. And then obviously we need to go through AI training to make sure that every part of the system works correctly, that we're not leaking anyone's information by accident or providing anything that isn't relevant. But what I really, really like about our model, which Sophia actually found, was that although it talks about your genetics and your symptoms and everything that leads up to it, you can also explain like your background, who you actually are in the model, who you are and why these roles in your life maybe have contributed or maybe have not, or just your lived experience basically throughout this illness that you may have. And
Yeah.
I feel like also being able to see those people like, yes, I have experienced this as well. And I am a mother or this, but I feel as though even though I am a mother, which is what a lot of physicians say, oh, you're a mother, it's just stressed. You have kids, this and this and this. It's not just that you're a mother, it's because you have these other underlying things that are happening or other things that might have been happening to you, or just the idea that, or the feeling of not being heard to these physicians that other people can connect.
So it sounds like it might be able to tease out like, yeah, this person has kids, but their last delivery was 3 years ago. So it doesn't make sense that they're just as tired as this person who just had a really complicated delivery and a lot of blood loss and now they're breastfeeding. Like all of those things that sap your iron stores are not going on with the person that I'm talking to. So that doesn't fit. Yeah, I can see that happening. Where I can see some pushback, number one is, right, we talked about clinicians having egos and somebody saying, why is this like crowdsourced thing a replacement for, my 4 years of med school and 3 years of internal medicine residency and 3 years of hematology fellowship? Like, what do you think that this, beehive of people with high school degrees is going to do that I don't already know how to do?
So even though physicians may think that, I believe that our system, not only does it advocate for patients, but also allows physicians to collaborate with the patient. So it allows physicians to see, oh, here's the more scientific part. Here's what the textbook definition of the illness as well. But also because you're seeing how the patient feels or lived experiences, I feel like those physicians can not only take what they learned, but also understand more clearly how the patient feels so they can both collaborate onto the patient's illness. So it's not completely disregarding the physician and their learning and what they know. It's only amplifying their knowledge and what they know in order to completely heal the patient and allow them to understand, like, yes, I am here for you. Yes, I understand.
Got it. So in a sense, you're also crowdsourcing the physician side of things, and they may be able to learn from a colleague in the same field, across the country who, for whatever reason, they've never met at a conference. They don't have any friends in common, whatever, but they're doing exactly the same job. And now they can share notes in this secure environment. That's a great idea. I can see it though being, right, there's so many tools out there. We talked about sometimes you don't even know what you don't know. How is somebody going to come across this in the sea of new medical applications and recognize that, hey, if you're not already doing this kind of work like the current hematologist that you and your mom are seeing, how are you going to pick this needle out of that haystack?
In our project, we're using a smaller sample of patients to be able to test this project on. So obviously, we would probably have to reach out and communicate with medical offices or hematologists to advocate for our idea. And we would start with a smaller sample of patients and then test it on them and stuff. And I feel like if we continue testing on them and we work out the flaws, we see what we can improve on, I believe that if our system is good enough, if it actually improves the patient and also the physician, that we would be able to advocate it towards other medical practices, other hospitals, and we would have those hematologists or OBGYNs to back us up as well.
Sure. So, Sophia, it sounds like you guys are really proposing kind of a clinical trial of this model.
Yeah. And I agree with everything Taihi said about the small group, like the advisory group to start off with. And that's what the study with MyAva did with PCOS patients. I think it was 42 women who piloted the program first. And I think we would definitely need to be in conjunction with primary care to start off with. And so when these patients come in who maybe don't know about the condition and their primary care doctor is saying, okay, we need to refer you to a hematologist. Here's your referral. And also, here's this educational handout on this new tool that they're using for people who may or may not have this illness. So people can find out about it that way. And I think from there, people will talk. And I mean, things on the internet go pretty far. So I think from there, it could be good. And then from there, we can see what we can do with hematologists as well.
Sure. It also sounds like this might be a way of enabling a little bit more of a stay and play approach in primary care, where if the primary care physicians feel like I'm a little more comfortable now with this support tool, that I maybe don't need to refer to a hematologist. Because as you probably know, that puts 2 or 3 or 4 months extra waiting time onto getting to your diagnosis and getting to your treatment. You know, if the primary care can figure this out, realize that you can't tolerate oral iron and refer you a week or 2 later to go get an iron infusion, it's a lot faster.
Right.
How are you going to know if it's working?
I think the general consensus that the study we used came to was they interviewed all of the participants after they first rolled out the piloting program. And they did interviews and they based their metrics on whether or not the tool was effective or not based on the knowledge that those patients had about their health. So there was 2 in particular that we talked about. And what they were both in short saying was that they felt more in control of their body and their condition because like the educational portion of the system allowed them to have that kind of knowledge and have access to that kind of knowledge and actually gave it to them because I'm sure you know how it is. You're fishing through like a sea of research that's from the 90s and now it's 2026. So tool would have her most recent publications on like iron deficiency anemia. And it would be easier access and more patient friendly for people who may not like have the ability to fish through all of those studies, don't have the time to fish through all those studies and weed them out. You know.
And to your point, I had a recent update from a colleague who's recently retired and very knowledgeable in the general medicine world that shared that something like 1/3 of women may actually be iron deficient and most of them don't realize it. In the hands of somebody like that, it's like, why am I dragging around so badly? This might be the thing that gets them to ask the right question that gets them to care. So I'm excited to see where stuff like this goes. This is one of these uses that makes me excited about AI as opposed to all the ways that it scares me. I think this is a really helpful way of turning the big idea of, you know, listening to people into something really concrete. Like, how do we listen? Well, we listen by sharing ideas across a larger group of people and learning from each other. So thank you both so much for coming on the podcast. I look forward to great things from both of you in the future.
Thank you.
Sophia and Taihi talked about one very important kind of data that is often overlooked or dismissed: a patient's complaints of fatigue and exhaustion. Just as frequently, clinicians brush aside complaints and descriptions of pain, especially pain that is, quote, out of proportion to exam or lasts longer than, quote, normal. My next guests, Ryan Ross and Trevor Staab, share an idea for narrative pain consults, specifically to help younger patients get the attention they need when interacting with medical providers who think they should be all better already. All right. Good evening. We're back with a couple of my students from the course. I want to introduce Ryan Ross and Trevor Staab, who are going to talk to us a little bit about their project. But first, I want to hear a little bit about who these guys are. So Ryan, introduce yourself to the listeners, please.
Yeah, my name is Ryan. I'm a senior at Pitt. I'm majoring in neuroscience. And after I graduate this coming semester, I'll be applying to med school for the 2026 cycle.
Okay. Any idea where you want to end up? Say Pitt.
Yeah, I guess Pitt, wherever it takes me, really, but Pitt would be great. Yeah.
Sorry. I'm incredibly loyal to the school, having gotten pretty much all of my higher education there. It is what it is. Trevor, tell us about yourself.
It's going to sound strikingly similar, but I'm also a senior at Pitt, majoring in neuroscience and hoping to apply to medical school, not this cycle, but the next cycle.
Very cool. Okay, so look for you guys in the fall of 27, maybe coming through the rotations. So you guys did a really fascinating project that your classmates loved and that I really thought was awesome as well. You talked about the idea of doing narrative pain consults. So tell us a little bit about what that is.
Yeah, it started with the interview that we did for the project. I interviewed my friend who experienced an injury when he was in the later years of high school, and it caused him severe back pain, which ended up being chronic. As he went through this experience with the healthcare system, seeing different doctors and all that stuff, he realized that he wasn't really getting his questions answered, and he also wasn't getting the treatment that he desired. We came up with this narrative pain consults, which is basically a 15 to 20-minute time that's taken out specifically for the patient to give their story, so that they could be a little bit better understood, and just so that they would have the opportunity to have that uninterrupted time to tell their story.
Got it. So, Trevor, if you could explain a little bit, what was missing from these encounters that Ryan's friend had before with the doctors that he actually saw that would be added back in by having a consult like this?
It was mainly, our goal was to bridge the gap between the narrative of the patient in question and the interpretation of the physician. Because a lot of times, even though a patient might be feeling immense pain, if there isn't anything clinically relevant or any sort of test that's coming back that would be indicative of a certain treatment, they might be more likely to dismiss the way that they're actually feeling. And that way, there's a large disconnect between what the patient's actually experiencing and how the treatment's unfolding.
So I like the word you used of dismiss, because that's something that we talked about a lot in the course. A lot of doctors will use a phrase in their notes, pain out of proportion to exam. Like, if I can't see the thing that's making you hurt, then it must not exist. You're having too much pain for the situation you're in. What was going on with this guy that was, I remember you saying in class that he was really being pretty severely affected in his day-to-day life by what was going on. So that was part of the reason to get the story, the narrative, rather than just look at the physical exam and the clinical findings. What was going on in his life?
Yeah, he basically, within a couple week period from when the injury first started to when it got a little bit worse, he went from being an athlete who was playing high school sports, doing all the normal things that you would expect a healthy 17, 18-year-old kid to be doing, to not being able to do any of that stuff. Even like walking around was hurting him. I remember he would even walk to classes with a little pillow that he held, and he had to put it on the back of his chair to give him like lower back support. And it was just things that he never really expected to happen. Maybe super later in life, but definitely not at a young age of like 17 years old. So these were really things that were affecting him a lot, and not just affecting his life, but also affecting his mental health as well, because he wasn't able to do all the things that he loved to do.
Yeah. Ryan, you're describing something that I see a lot in my patients that are nearing retirement or have a work injury or something like that. But this is happening to somebody who's younger than you guys are now, but not even having yet reached the peak of his career as an athlete. And there's a certain loss of self, if I'm understanding you correctly. Like, the identity of being an athlete is gone. Sorry.
Yeah, definitely. And that's also specifically with these narrative pain consults that we came up with. There are 4 people who are under 21 years of age who are experiencing chronic pain. And Trevor could talk a little bit more about it, but one of the main reasons we did that was because a lot of time the physicians are biased to think that these young people don't really know what they're experiencing or don't have a full grasp of the pain, and they can push them to the sides often.
Yeah. Okay. So Trevor, you've been passed the baton. Tell us more about this narrative pain consult.
Yeah. So our interviewee, like Ryan mentioned, but he wasn't expecting to experience chronic pain at the level that he was experiencing at such a young age. And I'm guessing that the physicians that were treating him were probably also not expecting for someone that young to be experiencing what he was experiencing. And it goes back to what I was previously mentioning with that disconnect. Even though our interviewee was going through something that was completely uprooting his sense of identity, his sense of self. As an athlete, especially in high school, it can kind of become all-encompassing. You're going to practice after school, maybe even before school. You're doing weightlifting, you're doing club practice even after that, maybe. And it seems like that's your entire life. And in a lot of ways it is. And for that to be taken away all at once, it's very hard to learn to live with that. And then when that's paired with being dismissed and the feeling that your feelings aren't justified, it could be very disheartening. And
sure, I can see somebody in that situation saying, like, why would I be faking this thing that has left me with nothing concrete to fill my time with nothing constructive to do? Like, why would I choose that life for myself? Yeah, I completely understand the frustration at the dismissal. I'm interested in why focus this specifically on pediatric patients under 21. Chronic pain is a widespread problem that usually affects adults. So what was the motivation for keeping it in that under 21 age group?
I think part of it was the fact that we're around that age, so this is something that's directly applicable to us, but also the fact that, kind of like I said earlier, a lot of times young people who have chronic pain are overlooked. And we actually found in our research that approximately 1 in 5 young people are dealing with some sort of chronic pain. And that's a number that I think a lot of people wouldn't expect. So we thought that this specific younger demographic was really important and should be focused on in these narrative pain consults. And another big thing that we noticed was that, or I guess that we thought about, was that the experiences that you have with healthcare providers at a young age are things that will go on to shape your view of healthcare for the rest of your life. So if something happens to you in high school and you have a really bad experience, you might go through the rest of your life saying, oh, I don't want to go to the doctor. I don't think they're going to be able to help me. But if these young people did have a good experience, then it could be the exact opposite.
Yeah, you're talking about a bunch of really important things. The first of which, and I fell into the trap just now, is expecting the typical pattern to be true 100% of the time. And you're saying typical pattern's true 80% of the time, but 20% is a lot of people. And I think the situation Trevor described of the intensity of being a high school athlete, where there's practice at both ends of the day and practice outside the regular season, may be part of the reason why that's happening. There are a lot of athletes that get injured for the first time when they're preteens, especially in sports like gymnastics and skating and a lot of those sports where there's intense training before people's bodies are mature. So you make an excellent point that this is an overlooked group, but a big overlooked group. And first impressions are hugely important as well. Okay, so I'm on board, but I bet you guys can hear already the voices of maybe some of this guy's doctors saying things like, who's going to do that? That takes so much time. I already don't have enough time in my day for all my patients. It's such a huge burden. It's a waste of my time. It's not going to actually make any difference in the outcome, or even it's too expensive. Plus people who actually don't believe that he's in pain. But we're going to leave those people out of the side because I feel like they're probably hopeless. What's your response to somebody who gives you that kind of pushback? Because it will certainly come if you propose something like this, right?
I think it's more so the focusing on, maybe even if it's not 15 or 20 minutes, but even starting out smaller and saying, hey, if there's 5 minutes of uninterrupted time for a patient experiencing chronic pain, who also is under 21 years of age, to just be able to tell their story in a narrative way with obviously brief clarifying questions interspersed in between, and seeing how does that affect care? How does that even just affect subjectively how the patient feels about the interaction with the provider? And then maybe scaling it and expanding it to, okay, we can maybe train some of the medical assistants or some of the nurses to be able to do this and not dig into the physician's time, the very limited physician's time with their patients.
Yeah. And not to quiz you guys in the middle of an interview, but you remember how long it takes if you let somebody speak uninterrupted about their problem, how long it takes before they'll basically be finished and stop talking.
I don't remember. It was a long time.
No, it actually wasn't.
It was short before the physician started interrupted.
So but if you let them go uninterrupted, it's about 2 minutes. Yeah. Somebody can easily tell a story like that. And we even talked about the technique of practicing telling a story in 4 sentences. And you get pretty good at it. And then the clinician can go back and say, oh, you used this really interesting word there. Tell me more about that. and however much time they feel like they have to expand on certain things. But yeah, I love that idea. Let's forget about the 20 minutes. Let's do 5 minutes. An orthopedic visit might be 15 minutes. You give somebody 5 minutes to tell their story. You might only have 2 or 3 questions left that you have to ask them when they're done if you let them be uninterrupted. And then you've got 10 minutes to do your physical exam and talk about the plan, make sure that they're okay with it, and send them off to get their x-rays. I think that sounds like a great idea. The problem is not everybody is savvy like you guys are to be able to figure this stuff out. What do you say to someone, if you're the clinician, to prompt somebody who doesn't know what to ask for? Or if you're somebody listening to this, like, how do I get myself heard because nobody's listening? How do you start when somebody doesn't know what questions to ask? Whether you're a patient going to a doctor who doesn't know what questions to ask, or a doctor who's talking to a patient that doesn't know how to advocate for themselves?
I would say from the physician's perspective, interviewing, whether it's the clarifying questions during the 5 minute, if we scale it and expand it 15, 20 minute, asking open-ended questions that aren't just inviting a one-word answer, but allowing for the narrative to flow continuously. And also beyond just language, but just, are you facing the patient, right? Are you making eye contact? Are you giving them the most attention that you can in that moment? Are you distracted doing other things, typing on the computer, even if that is facing them, but giving them for 5 minutes or even 2 minutes your undivided attention and actively listening to everything that they're saying. And like you mentioned, maybe that decreases the amount of time that you need to ask the rest of your questions, and that precious time. If you prioritize the 5 minutes or 10 to 15 minutes with the patient and you give them your undivided attention, you can actually get a lot from that. And something that can not only be valuable for the physician in terms of how they listen, but also very validating for the patient because they actually feel like they're being seen and heard.
And you guys remember one of the textbooks that we used besides the one that I wrote was the Compassionomics, or Compassionomics, depending on whether you think it's economics or genomics of compassion. But those guys talk about even a 40-second concrete compassionate behavior in a visit gives people the impression that someone cares about them. And like people going in, your case is really relevant because it decreases the amount of pain medication people need after a surgery, right? So even 40 seconds of, hey, I heard the medical assistant that checked you in said you had not been able to play your sport since you got injured. That really stinks. I'm sorry that happened. I hope we can help you. And if that's all you do, and then you launch into the regular thing, think, oh, this doctor's on my side. And that might actually directly affect your perception of pain. I don't know whether you guys got that impression from the reading that you did or not.
Yeah, I think we definitely did get that impression. And when you said that about having the feeling that the doctor is on your side, that reminded me of a specific part in our interview when our interviewee actually said that he felt as if him and the doctors were on opposing sides and they were almost like fighting against each other. So yeah, I think if you could implement something like this and allow the patient to feel as though they're working on a team to get to a shared goal, it would definitely make a big difference.
Yeah, I love that quote that you brought in from the interviewee. And I think that maybe if you have the opportunity to implement this at some point, you run into a cynical doctor like the hypothetical one I mentioned, that's the way to sell it, right? You want to be on the same team with your patients, give them 40 seconds or give them 3 minutes at the beginning of the visit so that they can tell their story the way they want to tell it, and then let them know that you're on their side. And you've spent 3 minutes and you've bought yourself their loyalty so that you can do the work that you know you need to do to get them better. And then when you see pain out of proportion to exam, you might also be able to think back to, oh yeah, this guy just had his career that was going to be his ticket to a college scholarship and a potentially D1 athletic career and maybe even a professional career. Like, it's gone. So of course it hurts, right? Because he has nothing else to focus on but his back pain. So I think that might be your sales pitch if you're ever looking to put this into effect 5 or 10 years from now when you guys are Ryan, Ross, and Trevor Staab MDs instead of Pitt undergrads. Thank you so much for sharing the ideas behind the project. I can see why your classmates love this one so much. Thanks for your time this evening. Any last words for the listeners?
Yeah, thank you for having us on. It was great to be able to explain our idea, and it's something that we definitely hope we could make real in the future.
Great. Okay, I'll talk to you guys soon, and Trevor, I'll see you Monday night.
Yes, looking forward to it.
One of the core messages of the class I teach is that listening and responding is a skill that takes just as much practice as suturing or interpreting EKGs. Ryan and Trevor showed us that it's hard to hear what people are saying when their stories are unusual or don't fit the model we're used to. Medical schools often try to remedy this by having their students practice interviewing and communication skills with standardized patients, trained actors who play the roles of patients in a variety of situations. But as our final guests tell us, one important group is often missing from these programs. Guillermo Cruz and Shruti Chandrashekar point out that most SPs are adults, meaning that the unique skills required to interact with children and adolescents and make sure that those patients are actively included in their own care are often missing from those trainings. They propose a carefully crafted way to work pediatric SPs into the mix for medical students at our favorite medical school. All right, we're back. And for this part of the show, I want to welcome two more of my students, Shruti Chandrashekar and Guillermo Cruz. And they're going to talk to us a little bit about their project about pediatric simulated patients. But before that, I obviously want to know a little bit about them. And Shruti, could you introduce yourself to the folks listening, please?
My name is Shruti. I'm a freshman at the University of Pittsburgh. And yeah.
Okay. Anything else about the future or what you do?
I'm a molecular bio major and I'm on a pre-med track. Yeah.
Okay. Got it. And you're from where?
New Jersey.
Okay.
Like Central Jersey, yeah.
All right. And Guillermo Cruz from the other side of the state line in Allentown, PA. Tell us a little bit about yourself.
Hi, my name is Guillermo. I'm a public health major on the pre-med track as well. And I'm just excited to be here.
Okay, great. As I mentioned, you guys did a project about pediatric simulated patients, or SPs for short. Tell me a little bit more about that.
Yeah, we decided standardized pediatric patients throughout our research. We decided to tackle because our patient, who we discussed in our project, faced, unfortunately, a very traumatic and negative experience in the emergency room. And we felt that standardized pediatric patients and implementing those sessions into medical school curriculums and training could be a very helpful and insightful way to tackle that kind of issue and to prevent other children from experiencing that.
Gotcha. So, Shruti, clearly this was a younger person, not an adult that you were talking about. What exactly happened with them?
This was an interview that Guillermo did, but the person that he interviewed had received experimental allergy injections that were not FDA approved, which resulted in a severe anaphylactic reaction, which ended up in her being admitted to the ER. And a major issue that she had during her ER visit was feeling overlooked and unheard by her physician throughout the experience because of her age. Since the physician only addressed her parents when asking questions and not her, even though it was her that really went through the experience, he really did not feel that he valued her opinion as much. And we just wanted to fix that.
And if I remember correctly, Guillermo, this was somebody who was not a small child, but like early to mid-adolescence, so old enough to speak up for herself.
I believe she was she was 9 years old, I believe, when it happened.
So that's a tricky age, right? Because on the one hand, you look like a small child. On the other hand, you've got opinions. I've known fourth graders in my lifetime. I've parented 3 of them. And they definitely have opinions. Tell us what your intervention does. A lot of the folks listening may not be familiar with the idea of an SP, of a simulated patient. So what is that all about?
Yeah, so I can explain that. Standardized patients are essentially people who are trained and hired to enact like medical scenarios and as a test for medical students to interact with and to practice like different communicative skills like diagnosis or just simply interacting and talking with the patient. These standardized patients act as conduits for these medical students to practice those kinds of skills. And during our research, we found that while standardized patient programs are typically popular, standardized pediatric programs are a new emerging field and that is currently being explored across like many different curriculums right now due to that exposure and meeting with a child rather than an adult who might be able to communicate better with you.
I got you. So what I'm hearing is that standardized patients are widespread, but most of the standardized patients that people interact with are adults. What are some of the obstacles to being able to put something like this in play? I'm not yet asking the cynical question, like, why should we bother? But it sounds like it's been hard if it's taken as long as I've been in medicine, and we still haven't really gotten to the point where we have a lot of these. What's preventing that from happening?
Something that we addressed in our paper was that like child labor and exploitation laws, there was like a lot of things about the hours that they can work and if they're really like consenting to being a standardized patient, but there are laws that are in place to help that. I was just like, it's definitely, you can work around it. But I think that was something that like affected if it was really going to be implemented because the laws for children were a lot more constricted.
I got you. So I probably shouldn't drag my 14-year-old into the med school and just make him sit there and pretend to be a patient for 6 hours. That might be illegal.
Yeah.
That was definitely a concern.
I'm glad I didn't go that direction. Seriously, though, so I'm interested in what kind of skills you feel like people are going to learn from having this opportunity with a child or an adolescent actor rather than an adult actor. What's different about that interaction maybe than the interactions that they learned from an adult actor?
Yeah. So if
you got it, you go.
All right, perfect. So during our research, we went directly from like the original studies pertaining to the diagram of the life world versus the voice of medicine. And we found that during those studies, they specifically reported that while all the studies performed were, of course, like accessible, and they, of course, created that diagram, they mainly were with adults. They were mainly with people who could speak to the doctors properly. They were mainly with people who could speak the same language. They were mainly like just people that could share that domain and could actually properly communicate. With a child, we found that that's not always going to be the case. That child isn't always going to be able to communicate as properly or as professionally with you as another adult may. So we wanted, ultimately, in implementing pediatric patients, would increase the compassion and understanding and allow more open-mindedness for medical students and for people participating in this so that they can breach maybe those additional barriers and accommodating to the child and lowering themselves to that level rather than not having to move at all because you have another adult standing in front of you that can understand everything you're saying.
So talking to the parent is a path of least resistance, but that doesn't make it the most effective way of providing care. It's almost like you're saying that being a child or an adolescent is like you're from a different culture or speaking a different language.
You could absolutely say that. One thing that we also discussed in our paper is the concept of linguistic relativity, where essentially a person's native language and their thoughts are determined by their culture, by their language, by how they like talk to other people. And we concurred that medical students and doctors, after going through the process of medical school and residency, that their way of speaking and this professionalism and like with these medical terminology, that they might not be able to necessarily interact as properly with patients, especially pediatric patients. And even in our scenario specifically, our patient in our story had her own things to say. Like she knew exactly when she began the anaphylactic shock. She knew like the timing of everything. She knew what was happening to her. She just didn't have the chance to communicate it because the doctor chose not to.
I gotcha. No, and that's interesting in particular because you talked about the linguistic relativity for med students. Like they have that problem with grown-up non-medical people. I feel like the same thing happens to people as they're entering adulthood. Like you go to college or you go get your trade and you go out into the work world and different things become important to you. And pretty soon it becomes hard to talk to your kids and hard to remember what it was like to be one because you've got different language about the world you live in. Yeah, that's a great concept to take with us. I'm reminded of something that occurred to me when I was doing one of the other interviews. They were talking about an adolescent, an older adolescent, 17-year-old who had a painful injury. And I remember learning as a pediatric resident that there are different ways that children of different ages will express the exact same pain, right? So a child with a urinary tract infection who's like a toddler won't say that it hurts, and it won't even be clear that they're having a problem with their urinary tract. They'll just have a fever and they'll feel sick and that I don't feel good, whatever. When they're about 4, they'll start to say, my belly hurts, and they'll point to their belly button. Now, that's not where we pee from. That's where it is. Only after about 7 years old will a child who has a urinary tract infection say, yeah, it hurts down here, and point to where their bladder is, or say it hurts when I pee. Any age younger than that, and that's exactly it. You have to know how to translate that language into what you're actually looking for. And that's kids who speak the same language, the same spoken language as the doctor, let alone kids from a different culture. Okay, so that's great. We all agree on that being a really valuable thing. But Shruti, there are going to be people who say, I don't need this. What kind of challenges did you guys anticipate to implementing this kind of program? And what would you say in response to getting those challenges?
There was things that came up that was like, parents are a very big part of trying to go over, like, work around the linguistic relativity, like the language barrier between the kids and the doctor, and they're going to be in the room. So something that they came up with was like having the child's parents act as a dyad to help the parent and the patient and doctor interaction, and having them as a dyad would help the medical student in our sessions. It would just help the transition with speaking. We'd have the medical student speak with the child alone and then speak with the dyad, just so the child can convey what they wanted to say, and then also have the parent like fill in the blanks for the medical student, just in case that they wouldn't really understand what's going on.
Okay. One of the big complaints of medical education is the lack of time. We were already talking about, like, we're trying to cram so much stuff into 4 years of medical school, and we're already looking at compressing, like at Pitt, at the medical school, at the fine institution of undergraduate learning that you go to, they're squeezing the whole preclinical curriculum into 18 months now. It's not even 2 full years to give more time for people to go out in the clinic. Where do you see fitting something like this in to that kind of packed in, no room at the end kind of curriculum?
I can answer that question. Again, I'm referring back to our research. We did see one medical school. I forget the exact name of it, to be honest with you. But one fellow medical school began those sessions actually from, I believe, like their first year. Like they implemented them their very first year to prioritize that compassion and understanding, and actually like increase that understanding of the patient, so that they are more prepared for those interactions, not just going into their 3rd or 4th year, but also just in general. And we find that could be very effective in tackling that same issue that may be present in Pittsburgh as well.
So making sure, for example, like in the patient interviewing class that I took when I was a first-year med student, that there were a couple of kids in the mix, because that was one of the very first classes I took. That makes a lot of sense. I remember also that you guys said that there was a particular advantage to Pittsburgh maybe being a place to pioneer this, or at least adopt early. What were some of the reasons for that?
Yeah, the University of Pittsburgh already has an SP program that has been very successful. So we thought that just having like the pediatric patients also being put into the mix would be easy to implement and integrate through that program, and it would just be better for the students.
So it's an expansion rather than a new launch.
Yeah.
I think you also said something about the under the radar but very high level Pittsburgh film industry, no?
Yes, we did. We recognized that Pittsburgh, because of its unique environment, because of its booming, really, their film industry and acting industry, and a lot of film directors and actors actually love the city of Pittsburgh because of a number of reasons. It's both a financial issue, because apparently it's less expensive to film movies in
Way
Pittsburgh.
cheaper than New York or Los Angeles.
Much cheaper. So it's a very desirable area for upcoming actors, for upcoming directors to film their movies, especially with medical shows that we have already, like The Pit. And recognizing that further, surrounding the area, there are a lot of child acting programs. And ultimately, we find that this opportunity to act as maybe a standardized pediatric patient could be an interesting opportunity for those children as well. And for, in general, those programs because of the environment that we already have in Pittsburgh. So it's just capitalizing on that.
That's a tremendous idea. I love it. Okay, so we talked a little bit about what some of the cynicism would be like. For example, there's no time to do this. And I can see people also saying that I don't need this. What do you say to somebody? How do you broach the subject with somebody who doesn't realize that they're missing these kinds of skills? Like maybe to that ER doctor, who I'm sure is a very skilled emergency physician, rapid diagnosis, moving people through to treatment, really getting to the next level. I'm guessing that was probably a pediatric ER that this person went to, because usually you don't take kids who are having anaphylaxis to an adult ER. So how do we help people recognize, without insulting their very excellent skills that they do have, how do we help them recognize that maybe they don't talk to kids in quite the most inclusive way?
When doing our research, there was like a study we came across that was like many doctors were not very comfortable with examining, diagnosing, and treating pediatric patients. And the findings of this study were that there was a general lack of comfort with managing pediatric patients. So like the discomfort with physicians alone is an issue. And I guess parents could also gauge their child's feelings. So if during an encounter, the child is not feeling like comfortable, or they feel like unheard or unseen, the parent can vouch for their kid and tell the physicians if they're comfortable enough, like they can tell the physician, my kid can answer these questions. You can forward the question to them and not straight to me. I feel
so
like
you're actually advocate for more inclusion of their children. So that's one really good solution, is since the adult is the one that's maybe got a little bit more of the clinician's ear, they can be the one to say, hey, I'm not actually who you want to talk to. It's a great idea. Kira, what about you? What do you think we can do to bring this to people's attention?
Emphasizing that point further, what Shruti just said, like that really nails it on the head. We found it in our research that the discomfort increases with decreasing age in the patient. So ultimately, we can discuss with physicians that your clinical skills, your medical skills are absolutely like valid and you've done through a lot of training. However, we have patients like the ones in our story where even though figured it medically, you might have done everything right and everything you could have done, she still ended up feeling ignored, unheard, and emphasizing that you could still do everything perfectly and yet like medically, but not emotionally for the child can happen. Right. And that we can strive towards a future where that doesn't happen, implementing these kinds of sessions and increasing that level of understanding and compassion.
Yeah, for sure. And I think back to what you were saying before about linguistic relativity. My wife's a special ed teacher and she talks all the time about how to scan something for reading level. Is this text appropriate for a third grader to read? Is it appropriate for a sixth grader? And the same thing is true of the spoken language that we use, right? What's the right tone and emotional temperature and word choice to use when you're talking to a 15-year-old versus when you're talking to a 5-year-old? And I think a lot of us might be comfortable with one age, but not all the ages. And I got to be honest, as the guy in my early 50s, if I have to talk to a 16-year-old, one thing that's going to be running in the back of my mind is I'm really worried this kid's going to think I'm old and weird, because that's just a thing that happens. Like teenagers, basically anybody who's more than about 5 years older than them, they don't have time for. So there's that also. We all get embarrassed. But we know that there's pediatricians who have that magic about them. They could walk into any room, doesn't matter how old the kid is, and they can immediately flip a switch and they're 7 or they're 17 or they're 45 and talking eye to eye with the parents, and they can code switch immediately. I look at this and think this is a great project to teach people code switching that don't already have that natural skill. So thank you guys so much for doing this. And I want to shout you out specifically because thanks to Guillermo's public health background, you guys actually put together a budget for this. So I'm going to let you leave on a high note and tell me, as one of the cynical questions, right, how much is this going to cost? So how much is this going to cost, guys?
I believe the exact price was $10,648.15.
To do how much of this? It would cost that much for what?
That would be the total cost for the startup year. of it, of the program. So
Meaning
with that
for
in
like
mind,
one typical size med school class?
yeah, I believe we did a sample size of 10 standardized pediatric patients at first.
Okay.
And of course, unfortunately, while we were finding our prices for different things, I tried to use as much as like Pitt's standardized
Mhm.
patient program as much as possible. However, a lot of it was hidden fees, so I had to go to other places. So it's that number may seem high, but the advantages that you can see coming out of it is that one, it's its startup year. So it's typically going to get cheaper and less expensive as the years go on, as it becomes more established and foundational in like our program. And a lot of it was from averages from other schools. I do not know how Pitt would price out, for example, a room that they would use for these sessions. I had to get that from somewhere else. Like advertising, I had to get from somewhere. I had to estimate. The one thing that we were able to use was how much they pay standardized patients. And we were able to, that was a big chunk of the cost.
Sure. And Shruti, you were saying before, this is an established program, so you're folding these kids in. So the rooms and the instructors and all of that stuff is already there. You just need to snag a session or two out of the curriculum and say, instead of this case, we're going to do Maggie, who's 7 years old and has a UTI, right? And that'll be your new standardized case. So I think there's room there. And from what I remember, the small groups are usually 9 or 10 kids. So maybe instead of 9 or 10 students and the class is about 140. So maybe you're looking at 15 SPs, not 10, but okay. It sounds like a great ballpark. I'd love to see if this actually goes somewhere. And I look forward to running into you guys down the road and seeing what happened. Thanks so much for being on the podcast. I appreciate your time.
Thank you for having us.
These 3 wonderful projects have a common thread. Learning how to listen to voices speaking in idioms of distress that clinicians are often not able to hear properly with their current level of training. Whether because of age, language barriers, or culture, or because their disease presents in subtle ways that don't fit the classic pattern, people don't express their illnesses in the idioms, the language of the world of medicine, but in the language of the life world. They talk about how their sickness drags them down as parents, interferes with work, or saps their ability to enjoy themselves. This episode marks the beginning of a series of episodes linked to my most recent book, From Illness to Exodus. In that book, I argue that there's a very strong connection between the biblical story of the Israelites leaving enslavement in Egypt and the way many people feel boxed in and trapped by illness. Right at the beginning of that story, in Exodus chapter 2, we learn, God heard their moaning, and God remembered the covenant with Abraham and Isaac and Jacob. God looked upon the Israelites, and God took notice of them. The 13th century Italian commentator Menachem Recanati asked why we need 4 verbs to explain the simple fact of God noticing the Israelites. These student projects help to answer Recanati's question. Hearing is only the first step, becoming aware of someone asking for help. Remembering means not only remembering the covenant, in our case, the covenant that a clinician has with their patient to work together to heal, as Rabbi Harold Schulweis taught us. It also means digging deep into the resources we study as clinicians in training to remember not just that magic number that qualifies a person for a particular diagnosis, but all the other idiomatic ways that the disease might present. When a person tells me they can't sleep on their right shoulder because that hurts, that's an idiom for rotator cuff sprain. Recanati says this verb means remembering with mercy, as we remember thinking, ow, a rotator cuff tear. That sounds really painful. Those 2 actions lead to the last 2. Looking might be rephrased today as making a patient feel seen. It's not just doing a physical exam, giving someone the once-over, but seeing with understanding, putting the pieces together to really comprehend what the person is going through. And that leads to knowing, not to having book knowledge, but intimate knowledge of what the person needs, how best to help them. Getting to this level of hearing a call to action isn't a matter of routine unless we make it one. As we learned at the beginning of this episode, it takes, quote, daily, undramatic yet essential service to move from good intentions to concrete action. Passover Seder is a millennia-old ritual and pedagogical tool to make sure the lessons of the Exodus become part of the fabric of our lives. The projects you heard about in this episode create new rituals, super modern ones like the use of deep computer learning, and more traditional ones like structured storytelling and role-playing to instill strong listening behaviors, getting us to lean in hard so we can hear what's going on. Thanks so much for listening to me and them. Moving forward, I'll be dropping new episodes every 2 weeks, and the next several will dig further into this link between illness and the Exodus story. I'll be joined next time by my friends Aviva Rosenberg and Karen Moshinsky for a discussion on how storytelling helps us understand illness, our own and other persons, or in a group of folks we're advocating for. If you want to learn more in the meantime, check out the book. Go to healerswholisten.com/from-illness-2-exodus/ and click the Buy Now link to purchase from the publisher. Use code all caps CONF40, the number 40, at checkout for a listener discount. I hope you'll enjoy and grow. Thanks for spending time with me today. If this conversation sparked something in you, subscribe so you don't miss the next one. And share it with a colleague who could use a reminder of why we do this work. For more thoughts, explore my blog at www.healerswholisten.com/blog or follow me on Instagram at healerswholisten. For deeper dives, check out the book version of Healing People, Not Patients, or my second book, From Illness to Exodus. Links to both are in the show notes. Our theme song, Room for the Soul, is available on Bandcamp. It's a reminder that together, we can find room for the soul in medicine. This podcast is not medical advice, nor is it legal or financial counsel. It's a space for reflection, rooted in stories, spirituality, and the art of healing. For your own care, always consult the professionals who know you best.